So, ladies and gentlemen, the problem is, how do we do guidelines? Are guidelines useful? And why they have been useful, and possibly today they are less of an interest. So the paper is the new generation guideline implementation. Well, when you develop a guidelines, there are rules. There are also a blackboard where you put all your ideas, and then you develop the guideline. This is the Italian guideline on asthma. So I think we need better. Well, what are the unmet needs in allergic rhinitis? First of all, early diagnosis and management. I think that we discussed that this morning. Daily follow-up and advice of symptom control, electronic monitoring, control of all patients, patient stratification for better management, patient compliance, patient empowerment. I think that you would agree. And then two things, rhinitis in the elderly, because we do not know what is rhinitis in the elderly, and 20 to 25% of the elderly people have rhinitis now. And it's easy. When you have rhinitis, you are complaining. For diabetes, you need a blood test, and for hypertension, you don't notice. And then, from a guideline to a simple implementation tool. Because the problem of guidelines is that if you put the guidelines one on top of the other, then you need a very high ceiling, because they are very soon going to be there. So I would like to present to you what is aria, and why aria has switched from a guideline-based project to an implementation with ICT. Well, aria 2000, So the aria initiative was developed, and I think that this is quite interesting. This was in 1999 as a state-of-the-art for all stakeholders, including patients. And you remember that we had IFA very early with us. Secondly, to update the knowledge of allergic rhinitis, to highlight rhinitis and asthma multimorbidity, and this has been the first guideline in multimorbidity in chronic diseases, to provide evidence-based diagnosis and treatment, to propose a stepwise management strategy, and this was also very innovative, to propose a global approach, including developing countries. And I got the International Union Against Tuberculosis and Lung Disease as a partner of ARIA, which was absolutely remarkable at that time, because when I met them, they told me, we're interested in TB, why rhinitis? Well, they have changed since then. So this paper has been cited quite sometimes. But what was very interesting, it is that we had 52 translations of the pocket guide. And this is very important because it shows how you can spread. So from there, we had the update. Well, the update is even more cited. And what is interesting, it is that we use the same evidence-based system. And this evidence-based system is ridiculous, because everything is in A. Someone said that yesterday. Why everything is in A? Because you need at least one randomized controlled trial to say A. Well, for example, you have 5 patients in a group, 3 in the placebo. I'm not joking. It is A. I'm not joking. It is the way the Japanese have approved the anti-allergic drugs, 5 and 2. Sorry, but 3. So there was a significant difference. And when everything was as good as the product, which could never be approved elsewhere, that was tested, it was approved. So you know, A is not good, and this system was not acceptable, and everything is in A. And we know that this cannot be. So we also had, with this time, the primary care physicians. I think this was quite interesting, and IFA as well, because IFA has been our partner for now how long, Susanna? Almost 20 years, no? So next, the revision. So we felt that this system of evidence-based medicine was not sufficient. So the revision is, you need to take the grade approach, and this is what my friends from McMaster told me so well, because they are remarkable people. You need to assess what are the desirable effects, the symptoms, the quality of life, the use of medication, and the development of asthma. Is Claire here today? No, she has gone, no? Because otherwise, we discussed that this morning. And then the undesirable effects, which are the costs, the adverse effects, and the burden. So this is how you need to do. But this is not the scientific approach. This is an approach which might be, it's not easy to know what is the burden and how you are going to decrease the burden. So the grade system is this system which is important. And very interestingly, you know who is Godot Rossi here in the paper? Yes, he's the current director of EMA. So he was there when we devised aria. I always like to use with nice people. Well, this is what we have done. And this is a very complex system. It took 2 years. First of all, we took the allergy document. Then the clinical experts proposed 42 questions. The methodologists developed 48 questions with a grade pro. And then they sent back the results, and we said no for 31 questions because they were not related to what was thinking. And many of you have participated to that. So I think this is very interesting to see the way people do, and this has been developed by methodologists. So we published the paper, and this paper is now highly cited again. And what is interesting, it is that, the recommendation may not be what is the evidence level. So for prevention, we have 3 strong recommendations with only 5 weeks and 6 very weak strength of evidence. Why? One of them is passive smoking. Of course, we recommend passive smoking, but not for allergy. The second is breastfeeding. Of course, we recommend breastfeeding, but not for allergy. So you need to go over. But also what was very interesting is that we could differentiate children and adults. We cannot do that for the elderly because we don't have the data. We then tried to know whether this guideline was the best among the others, and in particular with the American guidelines. And you see that the bigger the black or the gray square, the better. In fact, it was easy to see that ARIA 2010 followed the AGRI 2. So we have a guideline which we think is quite good. Okay, so now the problem of that is, what is the impact of ARIA? Well, if you apply the guidelines, you will see that you are considering 7% of the patients seen in primary care, because the guidelines are based on randomized controlled trials mostly, and only 7% of patients seen in primary care can fulfill the recommendation or the criteria for a randomized controlled trial. So it's a bit of a problem. Now, the impact of ARIA, it is that it is accepted by governments, but very interestingly, if you read the second line here, for the ACA results, and this is the EMA, persistent, moderate to severe house dust mite allergic rhinitis, despite the use of symptom-relieving medication. This is exactly the classification of ARIA and what ARIA has written for immunotherapy in 2008. So I'm delighted to see that were followed by national agencies or by governments. Now, we wanted to know what is there. So we made a summary of 10 years, and there are 450 people here in 72 countries. So we are deployed now in 72 countries, many more, by the way. So this, I think, is quite interesting to see that all people who came in ARIA are still there. So now, okay, we have a guideline. It's not used, so this is a problem. And governments don't take it easily. So can we reverse the system and start by governments or regions and go to the guidelines? And this is what we have done with MagVia. So MagVia is a reference site of the European Innovation Partnership on Active and Healthy Aging. Well, this is something very official. Now there are 74 reference sites. So I'm starting now to go from the top to the bottom instead of going from the bottom to the top. And we were helped by that by my good friend Bolesław Samolenski, who was also there, Susanna. And this was in Poland. So Poland recognized chronic respiratory diseases, and particularly childhood asthma, as a priority. And this has been written in the official organ of the EU. And it is prevention and control of asthma in the EU from the public health point of view. Because we need to have a public health perspective if we want to go forward. And this paper is very interesting because it is the first to try to promote active and healthy aging by assessing asthma very early in life. And this was a shock for the EU officers because they were thinking that active and healthy aging was starting at 65, whereas it starts in pregnancy. So we also, I proposed to the EU to have chronic respiratory disease as the model of chronic diseases for aging. And this is what has been accepted. This is another of my nice papers which are favored by my assistants because they have to submit the paper. And in fact, it is not only the EU, but it's also WHO. And this is something, well, how did we do it? Well, GUARD was by NGOs, government organizations, patients, and Ministry of Health. And this was GUARD. But WHO became a very difficult place to work with very many people around, and most people didn't want to do anything when Nikolai Kaltayev left. So I transferred the GUARD project to the EU in terms of airways integrated care pathways. I added some research, and I added also the European Innovation Partnership on Active and Healthy Aging Action Plan, and we did airways ICPs. And now it has been published twice, and we have plenty of plans on that. So now MagVia Aria 2016. MagVia is our reference site of the partnership. And Aria, you know what it is. So we combined the two, and in fact, it is for everyone now. So, first of all, we wanted to go from a guideline to an integrated care pathway in asthma and rhinitis comorbidity. Integrated care pathway is not a guideline, but it is the application of guidelines, because integrated care pathways, doctors need to follow them in some countries, like in the UK. Well, how an integrated care pathway differs from a guideline? First of all, there is a multidisciplinary team from the patient to the physician, with the pharmacist, the GP, and the specialist. So this is very important because this is real practice. Secondly, they have a focus on the quality of care and coordination of care. Thirdly, they need to have a mechanism for recording variations and deviations. And this has not been done by many guidelines. So if an alteration in practice is identified, this is a variance. And if you have a variance, you need to amend the guideline. So what did we do? We assessed ARIA for everything. First of all, the classification. Well, the severity is now recognized across the world, except in Spain. It's simple. You have either mild or moderate severe. Don't make it complex. And in VAS, it's below 5 or over 5. Make it simple. the persistence is not associated with quality of life. And the persistence is something which was proposed by aria, but that was not probably, well, that was probably to be improved. But it is associated with the prediction of efficacy. Well, it's simple. If you have persistent rhinitis, if you take 1 day of drug, it may help for 1 day, but you are going to get rhinitis later. It is associated with the duration of treatment and with asthma comorbidity. However, problems. Most patients consulting have moderate to severe disease, and most of them receive antihistamines plus inhaled steroids, intranasal steroids. But this is not in the guideline. So more than 60% of the patients treated by doctors are outside of the guideline. We have two things. Either we try to educate the patient, or we try to change. Educate doctors. It will take 20 years. So we try to change. So this is our graph, and this is a very interesting graph for me because it has been approved now for other diseases. We have patients with allergic rhinitis, and they are self-management, or they don't know they have the disease. And possibly, this is 30 to 40% of rhinitis sufferers, and some of them have severe disease. Many of them go to the pharmacist. In France, 60% of the people going to see a healthcare professional go to the pharmacist. And here, you need OTC medication, but you need a very simple tool. And then you have primary care. The patient can go directly to primary care or to a specialist. But we need probably to try to make things better so that specialists will only see people who are very severe, GPs will see people who are not controlled by pharmacy, and then this will be cost effective. And in fact, we designed a system which would fit for all of this with the VAS, the clinical decision support system, a tablet, and a cell phone. So using the same question for all people will facilitate the dialogue. Now we need to rank interventions in stratified patients. And this is very complex because there is no good guideline telling us how to stratify patients. So what we did, and this is again with the whole group of aria, 450 people. So what we did, we tried to understand how we could make this available, and we publish it. So first of all, we said, well, look, if you're untreated, VAS less than 5, you initiate any treatment because any treatment can be available. You take the patient's will. I prefer an oral drug. I prefer an intranasal one. I prefer no drug at all, which may be the case. And then you reassess daily. And the day 3 was discussed, and you, Klaus, you said, well, I want to have a longer treatment. Well, I can tell you that the patient's experience, it is not day 3, but it is day 05. They want to take the treatment and to get an immediate relief. Otherwise, they are not happy. And they change that treatment by themselves. So, if you have a VAS over 5, you have intermittent rhinitis, it is NA. If it is persistent, it is clear that it is with intranasal corticosteroids. And then you reassess the VAS. So these were charts which were derived by 450 people, accepted and published in the JACI. And we had also the treatment control in treated symptomatic patients, because these differ. And you see, well, we're not going to spend a lot of time there, but I think it is important that we have a scheme. So now, how are we going to populate this scheme? Well, most recommendations are valid in 2010. It's clear that oral H1 blockers in adolescents and adults are effective. Intranasal H1 blockers, intranasal corticosteroids, anti-leukotrienes, hypertropium in some cases, intranasal or oculochromoglycate. But the only comparison we had in this study was the comparison between intranasal corticosteroids and H1 blockers. So there is a very interesting paper, but it is totally negative. In this paper, which has been done by the Agency for Healthcare Research and Quality in the US, in fact, there is a problem. It has been sponsored by HMOs. And HMOs wanted at the end of the day to have no difference between treatments. So if you put the bar high enough, you will find that every treatment is the same. But it is a great evaluation. So a great evaluation can give stupid results because any patient will know that treatments are different. There is this paper by Eli Meltzer. It is very interesting indeed. And in fact, what we are proposing, and this is approved by many, I think that many of you have done that, we have 5 treatment steps. Antihistamines, antileukotrienes, and chromones are step 1. Intranasal corticosteroids are step 2. Intranasal corticosteroids plus azelastine, step 3. Step 4 is a short course of oral corticosteroids. Believe me or not, it's still largely used in Europe. And step 5, it is when you have done everything, you are going to a specialist and or allergen immunotherapy. I had many questions on allergen immunotherapy because people were thinking that we should start earlier. But this is for the acute treatment. So since we are recommending to patients what they're doing for a week, you cannot start immunotherapy there. And Yona, I remember your No, but I remember exactly the comments from all people. The second thing is that we had 8 questions on the approach, 10 questions on the step up, 11 questions on step down, and 3 questions on initiation strategy. So what we did, Ruth Murray took all the questions and put them on a monkey survey. So we went to the monkey survey, and we saw that there were clusters that were not appropriate. We had in total 51 people answering in 20 countries. So it is really a global approach. So we revised the questions. And revising the questions, we came with 3 groups which should be better. So here, we improved the question, and I think this is correct, and this is the question on immunotherapy, indicating that it is for the acute treatment and not for the long-term treatment. So, we complied with what you said. And this question, nasal congestion, was added. But 2 weeks later, I understood that this was wrong, because in fact, people do what they want. They don't care whether they have nasal congestion or not. And I tell you, they do exactly what they want. So you can propose to step down using intranasal corticosteroids, they won't do it. If they are better, they stop. And if they're worse, in the afternoon, they reinitiate their treatment. So, it's very interesting to do this kind of approach, but you will know after that the patient is the key player. Well, this is the way Airbus helicopter is able to do a looping with an electronic decision support system. And in fact, this has been done by the École des Mines d'Alès, which is 60 kilometers from Montpellier. So we use the same people who did the algorithm for the Airbus helicopter to do the algorithm for our app. And this is, for example, this is one example of what this lady has done. Well, I'm not going to discuss it because I don't understand what she's doing, but Ruth, who has analyzed this very clearly, told me that it is okay. And in fact, we don't have only 35 questions, but we have 10 more, because there were 10 more possibilities. So you see that we started from a guideline, and we went to something which is far more complex. And now, it is from a guideline in paper to a demonstrated mobile health tool, which I presented yesterday. So you see why I was interested to go into a mobile health tool in order to apply what we're doing. Well, I see that they have 5 seconds left, and thank you.